Hi, I'm Dr. Kim Keebler, Editor-in-Chief of the Multiple Chronic Conditions Resource Center, and today we are pleased to introduce our guest, Richard Knight. He's not new to us, but he has a lot to say. He's an advocate, educator, and kidney transplant recipient, excuse me, who has spent more than 2 decades fighting for patients who are often lost in the healthcare system. Richard holds an MBA and serves as adjunct faculty in the College of Business at Boise State University in Maryland. He himself lives with multiple chronic conditions and has been a kidney transplant recipient for 20 years. So when he talks about his work, he's not speaking from the outside looking in. On the national stage, Richard has served as president of the American Association of Kidney Patients and has shaped health policy through the Agency for Healthcare Research and Quality and the National Institutes of Health. His commitment to patient education and quality kidney care has earned him recognition from 2 of our nation's presidents. President Trump presented him with the Presidential Volunteer Service Award in 2020, and President Biden honored him with the President's Lifetime Achievement Award in 2022. Richard also serves on the editorial board for the Multiple Chronic Conditions Resource Center, representing the patient perspective. And today he joins us as co-founder of the APOL1 Action Alliance, the first nonprofit in the country dedicated exclusively to APOL1-mediated kidney disease, with a mission to empower patients and families by bridging the gap between complex genetic research and accessible clinical care. Richard, we are excited about all that we can learn about the APOL1-mediated kidney disease. But before we get started, just to give a brief overview of what this all means. The APOL1 gene is recognized as a kidney risk gene. APOL1-mediated kidney disease is a rapidly progressive form of proteinuria kidney disease. Although this gene is autosomal recessive, the risk comes from the genotype of both parents. When we look at chronic kidney disease, patients of African ancestry and a confirmed APOL1 gene variant progress to dialysis 9 to 12 years earlier than those that don't have this abnormal gene. APOL1-mediated kidney disease, as I mentioned, is often associated with proteinuria, but is accompanied by a rapid decline in eGFR, earlier onset of kidney disease, including those in adolescence, and leads to a mean age of kidney failure in the U.S. of 45 years. Patients are often asymptomatic. Richard, we're excited about what you can teach us about this. And to begin, can you provide a demographic perspective on what the bigger picture looks like when considering African Americans who carry the APOL1 gene?
Certainly, Kim. And I do want to say thank you for having me on your podcast. I certainly appreciate the opportunity to share, and it's always good to talk with you about this. Healthcare providers are important in understanding what we can do to deal with APOL1, and nurses critical part of the healthcare team. I want to start with a statistic, and there's a lot of numbers here, but about 50% of African Americans carry at least one APOL1 variant. 13% carry the high-risk genotype, meaning both variants. And that's where the real danger begins. When you have the 2 copies, your risk for kidney failure is 3 to 5 times higher than the general population. And that's been something that has confounded many doctors and certainly many African American patients, such as myself. Now, let's take a look at that. And you briefly touched it, so I won't dwell on it. But for someone with APOL, and I'll say AMKD as opposed to the extended term, the average age of kidney failure is 45 years old versus 65 or mid-50s. When I went on dialysis, I was 54. So we're talking about people in their prime of their lives, working careers, taking care of families. And the kidneys are failing decades before then. And that's really what this whole discussion about, and that's what I'm hoping that we can communicate to our listeners here. The high risk variance progresses so that you end up going on dialysis, if you get that far, 9 to 12 years earlier. And I want to be clear, I am not a doctor. I've had the good pleasure of being around some very bright individuals, and I do a lot of reading. But the numbers are staggering. We're looking at a disease that is disproportionately devastating to black communities, and in most of these people, nobody's ever told them that they carry this gene. In the bigger picture, this isn't just a kidney disease, it's also a health equity story. Back to you, Ken.
That's, you're right. That is staggering statistics and something that I myself have just learned about. So, as a clinician who evaluates microalbumin and closely follows the EGFR in patients with poorly managed hypertension and diabetes, I often assume a lack of adherence to diet and medications. So that may not necessarily be the case. How would you recommend that clinicians consider these aspects in the African American patient population?
Kim, that's a great question, and it's very personal for me. I've heard that scenario from patients many times because they feel like they're being written off. Their numbers keep getting worse, and the provider will ask, are you taking, if you have high blood pressure medication, are you taking your medication? Are you adhering to their diet? But nobody asks the questions that's beneath all of that. And that's what this conversation that we're having is really all about. When clinicians, or one of the things that clinicians need to consider is this: if you have a patient with African ancestry, I'm going to emphasize African ancestries, whose EGFR is declining faster than expected, and their proteinuria is persistent, despite all the management that you're doing as their doctor or clinician, and the patient appears to be doing everything right, then we need to have a flag about APOL1. The disease is often asymptomatic. It simply doesn't present until significant damage has been done. And the patients aren't having pain. They feel fine. And because of that, by the time they come to your office or go see their doctor, they way past the point of safety. They may already be further down the road than the clinical picture actually suggests. So let me see, the second part of that, I don't want to forget this, is a high risk variance. They don't guarantee kidney disease, but certain triggers or things that you may have in combination to that. Inflammation, uncontrolled hypertension, such as myself, viral infections, HIV or COVID. That can be enough to push that susceptible patient over the edge. So if you have a black patient with hypertension, diabetes, and a stubbornly declining EGFR, don't stop. Don't stop the medication adherence, but we need to also ask about the family history. Think APOL1. And I really want to add there that I am currently being tested, so I'll find out the results. But that is so critical, and I've had conversations with folks that have simply insisted men don't take their medication, tend not to be compliant, and this is what happens to you. So that's very frustrating for many patients.
And clinicians. You
And
know,
clinicians, absolutely.
yeah. Richard, I was just thinking while you were describing this scenario, if, just in a wellness check, an adolescent comes into clinic and you notice that their kidney function is off, they have, decline in their GR, and would you consider genetic testing in that patient population?
Interesting. Yes. Because, again, one of the things that we're going to look at is that ancestry. I was the first one in my family with kidney disease. And I have concern for my kids. So we have to look at the ancestry. And we think in doing that, that will give them a better idea as to what the possibilities can be. That which is one of the reasons why we have a pediatric nephrologist on our board. A patient with diabetes and CKD, you could be looking at a couple of compounding factors. And the thing that I want to emphasize here is that this disease can present as early as 18. That's why we try to work with HBCUs and other places where we're going to find young people. But I do want to emphasize that it can even happen at an earlier age. And when we have our empowerment summit, there's going to be a young man there, 14 years old, who was, I don't like to use the term misdiagnosed, but was not diagnosed because the testing was not done. His parents went out and had a test by 23andMe, and they insisted that they do the test, and that's what he had, APOL1. So your point is, it at least needs to be considered.
Yeah, I don't think it's on our radar, to consider the APOL1 gene variant. But among you've mentioned these statistics. Among people of African ancestry with diabetes, there's a 30% increase risk of chronic kidney disease and 80% increased risk of end-stage kidney disease. How can clinicians better understand how to best preserve the kidney function in this patient population?
Again, another great question. What does preservation look like? There's a few things, again, that we could take a look at. And I'm talking not as a clinician, but somebody who's kind of been inside this space for quite a while. First and foremost, earlier genetic testing changes the management conversation entirely. If you know a patient carries that high risk APOL1 genotype, you approach blood pressure targets, their proteinuria thresholds, just very differently, and their medication optimization, you have to be more aggressive. You can't wait. Secondly, and this is exciting. In the past, doctors, particularly nephrologists, haven't really had a lot to tell patients when something was identified. But right now, there are targeted research therapies and clinical trials that are taking place. One of our pharmaceutical partners, Vertex, has they're in trial with, let me pronounce it right, inaxaplexin. And what that does is something that directly targets the APOL1 protein mechanisms in the podocytes. This precision medicine, and precision medicine is so critical now, it's coming to a disease, it's coming to a disease that has historically been treated like generic CKD or chronic kidney disease. So nurses can play a huge role in connecting an eligible patient to those trials. And the third thing is this is where advocacy intersects with clinical care. We have to fight for earlier identification. Kidney disease in this population can begin in adolescence, which is the question that you asked. It doesn't always look like what we expected, but nurses paying attention to every point of their care have an opportunity to flag patients who warrant a deeper look. That is just so important. one of the basic mantras we have throughout the time at AAKP was early identification, slow the progression, educate the patient. The critical thing here is early identification. And in this case, it's more than likely going to be discerned by testing.
So it is important, like you've mentioned, to consider genetic testing for the APOL1 gene variation. I read, you mentioned African ancestry. I read in the US that the APOL1 risk variant may be present in people who self identify as Black, African American, African, Afro Caribbean, and or Latino. And, I certainly see a lot of Latino patients. And should
Mm-hmm.
I be considering the possibility of the APOL1 gene variant in that patient population?
Well, this is one of the important questions in the space because we always talk about African Americans, blacks, etc. But it's one that clinical practice hasn't fully caught up with what the research is telling you. The short answer is don't rely on how the patient identifies. Rely on ancestry. And let's take that a step further. APL1 high risk variants originated in West Africa. It's as a protective adaptation to African sleeping sickness. So the variants follow ancestry, not any label. What does that mean? A patient who identifies as Hispanic or Latino may have significant West African ancestry and carry the variants. Someone who identifies as Afro Caribbean, same thing. Even patients who present as mixed race with African heritage are potentially in this scope. And if we take that a step further, any patient with African ancestry, so whether they be Black, African American, but now we also have to take a look at the possibility with individuals with South Asian or Mideastern ancestry. Those are regions where historical African migration took place, so that at least deserves a conversation and consideration.
Yeah, that's really helpful, Richard, to better understand the origin of when to consider the possibility of this gene variant. It's confusing, you
It,
know.
it, it's very confusing. It's new. But again, I want to add that testing itself is commercially available. Natera, Quest Diagnostics. I have a kit right next to me because I have to complete my information with precision medicine care. And there are more companies who are involved in this testing. And also, as a patient, I always want to emphasize insurance companies are beginning to acknowledge and pay for this, which is so critical.
Very important.
And
Yeah,
again, I mentioned, so you had results. So what? What does it mean? Genetic counseling is part of the equation too. So
absolutely.
getting the results is one thing. Understanding what they mean is something else. So it's a team that will really help you address this.
Absolutely. So you mentioned the APOL1 Alliance Summit that you're kicking off this month. Can you let us understand more about the focus of your support organization and how clinicians can use this as a resource for their patients with progressive kidney disease?
Absolutely. And I'm so glad you gave me this opportunity to share because APOL1 Action Alliance was built exactly for the conversations that we're having right now. I have to mention my co-founder, Sharon Rouse, who's the president. She is an APOL1 kidney disease patient herself, living proof of everything we're talking about. She was diagnosed with FSGS but several years later found out that the cause of her losing her kidney was APOL1 variant, which is why she initially got involved in this. And I come from 2 decades of working with a lot of pharmaceutical companies, patient advocacy, including as I worked with the American Association of Kidney Patients, building these types of frameworks out. APOL1 was designed to focus specifically on this disease. There are a number of organizations, American Kidney Fund, led by LeVon Burton and Mike Spigler over there. They have really started the ball rolling here. Very collaborative, and when they found out that we were doing this, they reached out to us. Let's work together, and that's what I like about this. So our organization can be a focal point. We've agreed to set up a resource facility on our website, and we will have information from all the other organizations so that people, when they come to us, they will be able to get access to information, knowledge about that. I do want to say this. Yes, we're exclusively focused on that. I emphasize that because don't come to us for some other things. We're talking about APOL1, and we will refer you out to some of the other organizations that we know so very well. But back to our APO, what we call ourselves AAA, not to be confused with the other AAA. Our 4 pillars: patient education, advocacy, community outreach, and strategic partnerships. Right now, we're working with Vertex Pharmaceutical, Mays, soon to be Travere, and we're approaching others. We're active in the community, and that's our mantra: patient-led, community focus. And we have a program called Know Your Risk. We've got a program we're developing working with barbershops. Many of the young African Americans obviously go to barbershops. We're working and develop a program for them to have the information and knowledge. Working with churches, religious organizations. We're spending a lot of time doing that. But in less than, I'm looking at the calendar, what is that? 24 days, a little bit over 3 weeks, we will host our Empowerment Summit. And that's going to be held at the College Park Marriott and Conference Center. Now, folks like yourself down there in the lovely state of Georgia, you might not be able to come, but we have a virtual aspect. And that's my call to action for all the nurses and everyone who sees this. Please sign up. You can go to our website and get the information. We will have it streaming, so you'll be able to visit us right on time as we're going through the process. We're going to have patients, educators, practitioners, and a number of different information activities. We are even having a kiddie corner because if you happen to have a family, we want you to be able to bring your child. We will have someone to watch them and take care of them. We will have a couple of young people there. I work out at Bowie State University. I'm inviting some nursing students and some of the students that took classes from me because they're right in the age range where this begins to happen. So we're working in a very collaborative approach. If you line all the healthcare providers on one side and all the patients on the other side, there's still not going to be enough to serve them all. But serving as a focal point for this particular disease space is our role, and we're going to scale this to be national in scope. So we're certainly looking forward to it. And that's why right now we're at a turning point in this disease. I also serve on the board of the Personalized Medicine Coalition, where precision medicine is what we're trying to promote. And the Kidney Precision Medicine Project, where they're taking a deep dive in all things kidney. We have a database that has information about APOL1 samples, where we're doing a lot of testing and providing further information. So as an organization, we are aligning and working with all of these different organizations so that we're in a position to reach out on a community level and share information. And we certainly want to make certain that the nurses have access to this information. At AAKP, instead of going to websites for medical schools or something like that, many nurses would visit our site and get fundamental information. Similarly, with APOL1, you can do the same thing. That's going to be written at the layperson level, because obviously we want our patients to be able to come and read and understand it. But it'll also be, I think, a great resource for nurses and
Yeah.
your other listeners. So
For
that's
all, yeah, for all healthcare
Mhm.
providers, I think. Um, your leadership, your historical leadership, you being at the helm of this organization, this alliance, I'm sure will be successful and needs to bring a lot of attention for sure. But while you were talking, one of the thoughts that just I was just thinking in terms of kidney transplant, are these patients, are these recipients tested for this genetic um, variant?
we're working on that.
Yeah, I think that would be really important. You get a kidney that's affected by the APOL1 variant. No wonder there's some failures.
And the important thing is awareness. We understand and appreciate standards of care. Quite frankly, in our view, the status quo is not acceptable. Patients, folks like myself, we kind of have a sense of urgency, if you will, the immediacy of now. And these tests, when you think about it, the costs and the payoff, cost and benefit factor works out very well, because if you're aware, that doesn't mean that you don't do the transplant, but you're aware of it. And with the improvements that are happening now, shortly, we'll be able to treat it.
Well, Richard, we will put a link in this podcast to your organization and to the upcoming summit so people will have access to that. And as a member of the editorial board of the Multiple Chronic Conditions Resource Center, will certainly help to promote your work and your organization. You brought this to my attention, and I've been seeing patients for 43 years. So, to now have this different perspective, and, the demographics of African Americans in the South is pretty prevalent.
Yeah.
So, to use this in my daily my little toolkit, it is an important
That
new thing to consider.
it's an exciting time. And again, we want you clinicians to have more tools.
Absolutely. And to better understand what can be contributing to situation that we think it's one disease and it's actually a genetic variation of that disease. So
And
we
one,
really,
one last point that's
yeah,
very important. We're talking about APL1, but 37 million people in this country have kidney disease, and 90% of them don't know it. Just wanted to put that in the context. So that has a special impact on APL1 in itself.
yeah, I certainly see it a lot in my practice for sure. Well, Richard, you're awesome. Thank you so
Thank
much.
you for the compliment. I just happen to hang around with real smart people.
Well,
Our
and
president is a dynamic person. You're going to meet her, and she's really doing a great job leading this effort.
yeah, and you're moving quickly with your website and your summit and your messaging. So thank you for all that you do. And I'm sure we will have you on as a guest again. Um, so thank you. You
Thank you.
take care of yourself and good luck with
I
your
will.
upcoming summit.
Be safe, and thank you very much.
Absolutely.